Hello everybody and welcome to set 9 of the part 1 questions. Let's get going. First question here, a 45-year-old woman presents to the ER with complaints of chest pain, a racing heartbeat, and dizziness. Examination reveals a heart rate of 120 beats per minute, BP of 116/74, and 20 respirations per minute. The patient is diaphoretic and anxious. An initial EKG reveals ventricular tachycardia with a shifting sinusoidal waveform. What is this classic EKG finding? What are the possible causes of this patient's condition? So this is torsades de pointe, which means twisting of the points. So you might have to recognize the description of a shifting sinusoidal waveform, or sometimes it's called a polymorphic VTAC or variable amplitude VTAC, or they might just actually give you a 12-lead EKG or a rhythm strip. So you should be able to recognize this type of waveform. So very, very important to be able to see that and recognize it pretty easily. And it's not hard, it's pretty easy. Now, what are the possible causes of this patient's torsades? So basically anything that prolongs the QT interval can increase the risk of torsades. So lots of drugs will prolong the QT interval, some antiarrhythmics, some antibiotics as well. Things like hypokalemia and hypomagnesemia can increase the risk of torsades as well. So if you see a patient with this, one thing you're going to do is check electrolytes, and you're actually going to give IV magnesium, which we went over in a previous question, and maybe even potassium as well. Now there are also some congenital long QT syndromes caused by cardiac potassium channel defects or cardiac sodium channel defects as well. Next, how does an MRI differ from a CT for CT imaging? So an MRI uses no ionizing radiation, but the CT does. So just like an X-ray, we try not to do CTs on pregnant patients unless we absolutely have to, because that ionizing radiation is dangerous for developing fetuses. Now MRI is better for looking at things like soft tissue problems, things like the brain, spinal cord, joint ligaments, and cartilage as well. If you need to look at an ACL tear, you're going to get an MRI of the knee. CT is better for bone detail and recognition of blood. So excellent for bleeding, especially in the brain. So a patient with symptoms of a stroke, they might come into the ER, you're going to get a CT scan very quickly to see if there's any hemorrhage in that brain. With an MRI, you're using a big magnet, so you can't have any metal in the imaging room, but with CT, metal is not a big problem. On MRI, bones will show up gray. On CT, bones will show up white, just like an X-ray. So you might get that on a picture sometime on your test. Next question, what enzymes do obligate anaerobes lack? So obligate anaerobes lack catalase and or superoxide dismutase. So superoxide dismutase converts oxygen radicals to water and hydrogen peroxide. Catalase breaks down hydrogen peroxide to form water and CO2. Next question, a patient of yours with recent complaints of weakness, pallor, craving for ice chips, and tachycardia has a history of chronic hemorrhoids. What do you immediately suspect is the cause of this patient's anemia, and how do you treat it? Pica, which is the craving of non-food substances such as ice chips, sometimes even dirt, is a classic feature for iron deficiency anemia. Now here, the history of chronic hemorrhoids is a flag for rectal bleeding as a cause of the iron deficiency as well. The treatment would be iron replacement, but oftentimes we're still thinking about further diagnosis, so they might need to get a colonoscopy, especially if this is an older patient, and that's going to evaluate them for colon cancer. Next question, what is the antidote for digoxin toxicity? So the antidote is digoxin immune FAB fragments. But I'll tell you that we don't really use this all that often because it's really expensive and hard to find. Most of the time we try to normalize electrolytes like potassium, magnesium. We might have to give things like lidocaine for any major arrhythmias. Sometimes we'll also use cardiac pacing as well if things aren't going well. Next question, what embryological structural abnormalities might account for multiple miscarriages? What structures arise from the paramesonephric ducts? What other name is given to the paramesonephric ducts? So, first part of this, what's going to lead to these multiple miscarriages? One structural problem that can result in these miscarriages is incomplete fusion of the paramesonephric ducts. And that can cause a bicornate uterus, which can have varying degrees of severity. Now, what structures arise from the paramesonephric ducts? That's going to be the fallopian tubes, the uterus, and the upper portion of the vagina. Now, what other name is given to the paramesonephric ducts? That is going to be the Mullerian ducts. Next question. Hydatidiform mole is the most common precursor of what ovarian germ tumor? And what tumor marker is monitored after the dilation and curettage of a hydatidiform mole? So hydatidiform mole is the most common precursor of what ovarian tumor? Remember, this is the choriocarcinoma. And then what tumor marker is monitored after the dilation and curettage of that mole, where you're going to watch beta HCG. And that needs to be monitored, making sure it goes all the way back down to normal, because if it stays elevated, you're going to worry that you didn't get all of that mole out. And that little piece left over could potentially progress to that choriocarcinoma. Next, what are some of the circumstances in which information is HIPAA exempt, meaning that your health information can be shared with another party? So, child abuse, birth or death information, disease reporting of state-mandated reportable diseases, public health disease surveillance, and state-sponsored disease intervention activity. So an example of this would be a scenario where a physician reported to the state information regarding a patient having maybe a sexually transmitted disease or tuberculosis. The state then is going to contact that patient to determine close contacts, and it might also contacts for that STD and that sort of thing. Also, schools are exempt, meaning that they can ask for things like vaccination status. Next, a young woman complaining of easy bleeding and menorrhagia was referred by her OB-GYN for workup of her bleeding disorder. Your preceptor asks you, with determining the cause of the patient's condition, compare the clinical findings of platelet disorders to those of coagulation factor defects. That's a big question. So what you need to remember here is that platelets act first and form a platelet plug. So the first part of hemostasis is the formation of a platelet plug. Then that nasty coagulation cascade that you hate to memorize kicks in to generate a fibrin clot that is going to last a bit longer. So if you have a platelet disorder, you'll have a prolonged bleeding time, but PT and PTT will generally be normal. If you have a coagulation factor defect, the platelets are still working normally, so they'll be able to form that platelet plug, and bleeding time will often be normal. But the prothrombin time and the partial thromboplastin time will be prolonged, because these are determined by the coagulation cascade and your coagulation factors. So with a coagulation factor defect, bleeding time is normal, and either the PT or the PTT or both will be affected, and that depends on which factor you're dealing with. Then clinically, platelet disorders can cause small hemorrhages, things like epistaxis, petechiae, some purpura, that sort of thing. Coagulation factor defects can cause more major bleeding, like bleeding into joints called hemarthrosis, like we see in hemophiliacs, or intracranial hemorrhage, that sort of thing, bigger deal. Next question. You're reading a research article about the prostate-specific antigen test, and it mentions that the PSA blood test is associated with a high false positive frequency. In your own words, explain what false positive means. So a false positive occurs when the test is positive, even though the disease is not present. So the test is falsely positive. Pretty easy to remember. Okay, guys, that brings us to the end of set 9. I hope you learned something. I'll see you next time.